Optimal repair of airway defects may eventually be provided by revascularized tracheal allotransplants. Tracheal allotransplantation may be done in an orthotopical position in an immunosuppressed animal receiving daily intramuscular injection of cyclosporin. The problem with orthotopic transplantation is that the allotransplant will undergo necrosis because no reliable vascular pedicle can be used for direct revascularization of the trachea. A much better way for revascularization is the indirect heterotopical position. For heterotopical revascularization, the tracheal allograft is transplanted to the lateral thoracic area of a receptor animal. The fascia is wrapped around the transplant in an immunosuppressed animal, receiving daily administration of cyclosporin. The transplant can become revascularized in an immobilized position after closure of the lateral thoracic skin. As visible on an axial section, revascularization of the allotransplant takes place by outgrowth of blood vessels from the fascia flap through the membranous ligament and from the fascia flap through the intercartilaginous ligaments. The revascularization state of the allotransplant can be evaluated after different follow-up periods. To evaluate the areas perfused by the fascia flap after follow-up, the lateral thoracic artery of the fascia flap is injected with blue silicone dye. This material forms a cast of the vascular architecture of the fascia flap and the established vascular connections with the tracheal allograft. The first signs of revascularization can be seen on an axial histological section after 5 days of fascial wrapping. The blue spots inside the thrombosed vessels are the first signs of mucosal reperfusion. Squamous epithelium is visible on top of the partially perfused mucosa. Full mucosal revascularization is obtained after 14 days of heterotopical revascularization. The mucosal lining is blue-colored after blue silicone injection of the vascular pedicle. A longitudinal section shows a lamina propria which is fully perfused by the fascia flap with blue silicone inside the blood vessels, and the epithelial lining has regenerated into a ciliated epithelium. The allograft is fully perfused after the 14 days revascularization period so that it can be transplanted in an orthotopic position. Therefore, a 2 cm segment of native trachea is removed and the allotransplant is transferred to the neck with preserved blood supply. The allotransplant is sutured into the tracheal defect with proline 5O. A first suture is placed at the lower anastomosis. A second suture is placed at the upper anastomosis to stabilize the transplant. The upper anastomosis is completed with different sutures tied with the knots lying on the outside. The lower anastomosis can now be completed. The rabbit breathes spontaneously during the whole procedure. An axial MRI scan taken 2 weeks after transplantation shows the revascularized allotransplant with the mucosal lining, the cartilage ring, and the fascial flap. A coronal MRI section through the tracheal transplant shows the upper and lower transplant anastomosis. A revascularized allotransplant in an immunosuppressed receptor can not only be used for segmental transplantation, but can also be transformed into a patch after removal of the membranous trachea. The tracheal patch can be used as the optimal tissue in repairing anterior airway defects. An axial CT scan shows an anterior airway defect after reconstruction with a revascularized tracheal patch. This reconstruction can be evaluated macroscopically after injection of the vascular pedicle with blue microfill. The revascularized tracheal patch gives us the definition of the optimal reconstruction of an anterior airway defect. The respiratory lining ensures primary healing and mucociliary clearance. The elastic cartilage gives support to the reconstruction with anterior expansion of the airway lumen. And the fascial flap provides a good blood supply for the cartilaginous and mucosal components. This optimal repair tissue is not available in the clinical situation, and the search for autologous tissues approaching this optimal reconstruction was the objective of further research.